what you're looking at. I'll help you out. Severity is one.
Location and mechanism.
Yes. Location and mechanism. We already did these two. I mean, this one's looking at that Glasgow coma score, looking at
Cranial nerve reflexes.
reflexes of those cranial nerves off the brainstem. Also a CT scan will determine the severity of a traumatic brain injury. Location, that was the focal, polar, diffuse. And then the mechanism, we had concussion, and we got
Contusion.
into a discussion on the concussion of how that actually, they're finding out that it's not entirely no damage there, right?
So there is damage. Because we were saying that there was no brain
In
damage.
regards to the way we view it in this class, a concussion, there is, when they do a CT scan, they do not see any brain damage, okay?
No permanent brain damage, right?
But now they're finding out, this is where we got into that big discussion,
Mm-hmm.
that football players or military people, the repetitiveness of concussions, more than one,
Mm-hmm.
actually is probably going to lead into damage, even though at the time it's seen as no damage. And I really truly believe that's because of this continual hitting your head against something because of a certain profession you have. Right? We were talking about soccer, right? And how they don't allow kids to hit the ball with their head anymore
Mhm.
because they're finding out that type of repetitive behavior can lead to actual damage in the future. Cognitive damage, I would imagine, in some way.
Couldn't that be kind of similar to like diffuse because you're kind of jostling the brain within?
Yeah, maybe that's
the
what's
head?
going on. See, I don't think they entirely know what's happening. So maybe jostling the brain from that repeated hit injury there could be doing some type of damage to those axons. That'd be a great hypothesis. And then we had contusion, where we do have brain damage,
Mhm.
for sure. And then the last thing that we were going to talk about was hematomas. And so what a hematoma is the leakage of blood. You know, you could view it as a hemorrhage, but when we think of hemorrhaging, we usually think of an aneurysm. But in both of these situations, hematoma versus aneurysm, we're getting leakage of blood outside of that vascular system into the tissue that those blood vessels are associated with. Yes?
Is a hematoma always blood? Like,
Yes. Think of a hematoma as a swollen bruise.
Where it's raised from the skin.
Yeah, so like, God, I can't say it, ecchymyces
Mm-hmm.
is a hematoma.
Mm-hmm.
Where just a bruise where you don't have swelling, you're not having edema, that's just like broken blood vessel. You get some leakage of blood into that tissue. A hematoma, you're going to have edema occurring. And so it's that blood going out of the cerebral vascular system, the cardiovascular system, sorry, into the tissue where it's been damaged, okay? What was your question exactly?
well, I thought a hematoma was fluid buildup.
Yeah, but that fluid buildup is from leaving a blood vessel and going into the tissue.
Oh,
That's what edema is. It's fluid that's in your blood and that plasma going into tissue and building up there, all right? So when we're talking about inflammation, we're really talking about that volume of blood and what's in the plasma a lot of times going out of a blood vessel into surrounding tissue, causing inflammation, and the lymphatic system can't pick it up quick enough, so you get it inflamed or this edema, excess fluid in the tissues. Did that answer your question?
yeah.
Okay. So there's, and I wonder if I should draw this. And I'm not going to draw it. I'm going to draw this instead. You have epidural These are hematomas. You have an epidural hematoma, you have a subdural, and then you have a subarachnoid one. I mean, all of these, well, I'll draw it since you were asking about it. I'll draw a really crappy picture, okay? It's not gonna be as detailed. But here's your brain, all right? And I mean neurons here, right? And so you got your brain going on, brain. And then you're gonna have those mothers that are cradling and protecting the brain. What are the name of the mothers? What's the one that's the most deep of the mothers?
Pia.
Pia. This is the gentle mother. Okay, that's what Pia means. And so this is going to be the one that's directly attached to brain tissue. This guy is actually directly attached. There's no space in between. It's like directly adhering to that brain tissue, right? And then going deep to superficial, what's the next one?
Arachnoid.
It's either dura or subarachnoid. Subarachnoid, or the arachnoid mata is the next one. Or maybe I should do a different color here, purple instead of that pink. So then we have this subarachnoid, and it's called this because it has little connective tissue that looks like a spider web. Or arachnoid, sorry. And then the most outer one is going to be the dura. And so you can have a hematoma that is above this dura mata. Okay, so then you're going to get buildup of blood above this dura mata. Okay, that's the epidural one, because epi means above. This one here, think of it, then we get this buildup. And you're going to have, in all of these situations, compression, right? Because you're building up fluid in this space that is outside of your brain tissue, and that extra pressure is going to start pushing on brain tissue. The subdural, that's going to happen here. So this would be subdural. This is epidural. And then if you have buildup here, underneath the arachnoid, that's the subarachnoid hematoma. Everybody good? Now, this one here is going to usually be a consequence of you have a skull bone here, and it fractures because somebody came around and bashed you in the head with a hammer or a mallet. Okay? So this epidural one is going to be predominantly from skull fractures. And really what's causing this buildup of blood is blunt force trauma and the breakage of arteries. Blood is moving faster in arteries because it has a higher pressure. And so when you have this fracture occur, that quick buildup of blood in the epidural space is due to the breakage of arteries, all right? This one is very easy to have access to though, right? Because it's above these meninges. And so with the drainage of this hematoma, there's a good prognosis here. So this one is fairly easy to correct because it is above those meninges. It's more accessible, all right? The subdural one, this subdural one is actually, so if we actually think of our brain and that falx cerebri that separates left and right hemispheres, we have these veins that are called bridging veins up here, the dura sinuses. And so the subdural here is where bridging veins are broken. For subdural hematoma, is that one going to be as fast as an epidural one?
No.
No, because the veins, that's a low pressure. The blood isn't moving as quickly here. And so this is going to be slower in developing. And there's actually subacute. People can have a subacute subdural hematoma. And so this is chronic and very slow in this situation. And so as we get older, we just are not going to be maintaining our tissues as well. And so elderly people can have these bridging veins start to break and start to develop subdural hematomas, and they're then, instead of diagnosed with a subdural hematoma, they're diagnosed with dementia. Because this is going to have compression, it's going to hinder the functions of the brain tissue itself as this blood starts to accumulate in that subdural space. And then this subarachnoid one, this is also arteries. Arteries are compromised. And so you're going to start to see the buildup in the subarachnoid space. What is this going to lead to?
Intracranial pressure?
All of these lead to intracranial pressure. But what is in this subarachnoid space? Cerebral spinal fluid. So what's going to happen if you're blocking, you're getting a hematoma in the subarachnoid space? Hydrocephalus. So this particular one is going to lead to hydrocephalus. Okay? Is it obstructive hydrocephalus or non-obstructive? Remember? I like to think, are we blocking the pathway within those ventricles, or are we blocking the drainage of this fluid back into the vascular system? If we're blocking the passage within the ventricles, that's obstructive. If we're blocking the drainage back into blood vessels, that's non-obstructive. So this is, what is it, non-obstructive or obstructive? You got a 50-50 chance, and I just explained it. What?
Non-obstructive?
Non-obstructive, that's correct. You guys have any questions about this?
You said obstructive is blocking the blood or the drainage?
It's a lesion within the ventricles that contains cerebral spinal fluid within the brain. When we're talking about non-obstructive, that's whenever we're blocking this fluid from being able to go back in to the vascular system through arachnoid villi. And that's what this causes, actually, this hematoma. And this one is what we think of water on the brain then, because we're getting a swelling above the brain tissue here, right? Not within it, or like amongst it, I should say. All right, you can recess. All right, now the next thing is strokes. And there's two different types of strokes. There's ischemic strokes and hemorrhagic strokes, right? Ischemic strokes this is where you have an occlusion of a cerebral artery. Okay? So basically you're blocking blood being able to be delivered to brain tissue. That is going to lead into ischemia. All right? But you have to realize it's blocked. It's not like you're going to, I mean, the body could attempt to get blood there by doing vasodilation, but you're blocking this blood vessel, okay? Now, if you are not allowing blood to get to brain tissue, what's going to happen here with brain tissue?
Gonna die.
It's going to die, right? Because neurons are highly metabolic. So we're going to then get necrosis occurring. So this is the thing that we were talking about at the very beginning happening, right? You have this ischemic event. You're going to get the buildup of what neurotransmitter?
Is it NMDH or something, or AMDP?
Glutamate?
Glutamate, which will bind to these receptors on neurons, the NMDA and the AMPA.
Mm-hmm.
And then that causes what to happen in that neuron?
Calcium overload.
You get a calcium overload, exactly. And calcium overload is going to make it to where you're going to be having free radicals build up. That's going to damage them.
And that's from the reperfusion, right?
Reperfusion will also cause free radicals. Calcium overload and reperfusion both cause the buildup of free radicals. Calcium is because it's activating enzymes, so you're making enzymes start working when they shouldn't be. And so anytime we think about metabolic activity increasing, we're increasing free radicals. Think about the mouse again versus the whale, right? And that theory of cellular aging. If you have a higher metabolic rate, you're going to have more free radicals accumulating, you're going to have a shorter lifespan. Okay?
Now, would this necrosis be liquefactive?
And in this case, we're talking about brain tissue, and since it's highly metabolic, this will be liquefacitive necrosis. I'm not entirely really sure if we would put that in this area here right now, because it's not going to be like an infection. We're getting a bunch of pus, and we're having this happen very quickly. This could be actually in one particular area. It depends upon where it occurs, the stroke. Because you know people who have had a stroke and they don't die, right?
Usually it's people with hemorrhagic strokes that die quickly.
Right. So we're talking about an ischemic one, and so a certain area of the brain, there'll be a deficit based on where the ischemia occurred, all right? And so the thing, instead of calling it liquefacitive necrosis, the dead area of the brain is called an infarct, similar to when we're talking about heart tissue and an area of the heart that's died, an infarct, a myocardial infarct. And now we're talking about an infarct with brain tissue, okay? So this we call an infarct. So this is what will happen, all right? And you'll have an area of damaged brain tissue. Depending upon the severity of this ischemic stroke, around this infarct, you're going to actually have viable tissue that's called a penumbra, all right?
So you wouldn't have scar tissue?
I don't know how that results, if it's scar tissue or just a space there. I don't really know how it's physically looks,
Mhm.
this infarct, but it's dead brain tissue from this ischemic event. I don't know how it would look on a CT scan or anything like that. I'm sure that there's something they're looking for to see that there's this infarct, non-functioning neurons. It could be scar tissue. But then above this, you'll have a penumbra, where this is viable tissue. And if you are able to restore the blood flow, this penumbra could be saved, this viable tissue. When we're talking about this occlusion, the things that are causing this occlusion are thrombi and emboli. And when you think emboli, or an embolism, that means that this blockage actually originated somewhere else, right?
Mm-hmm. And it traveled?
Yeah. And so these typically of ischemic strokes originated from the heart. In regards to what's being blocked, so we're going to have I'm not going to draw this very well. Good. This isn't a very good drawing, sorry. Eh. Whatever. Oh, here, I'll do a branch here. I don't know the specific names of the blood vessels and all this, but this circle area in here, those are cerebral arteries. And the arteries on the left and the right side that actually distribute blood to these cerebral arteries, you got one on the right side and one on the left side. Those are your internal carotids. All right? They're going to feed blood into these cerebral arteries, and it's the cerebral arteries that are delivering blood to brain tissue. Okay? And as blood is coming into this circle of these cerebral arteries, it's going to be hitting here and here, and that could cause a weakening of the blood vessel. That's separate from what's happening here. But in regards to an ischemic event, you have an occlusion in the cerebral arteries. So that's where the thrombi are originating in this situation, is these cerebral arteries. So are we okay with that?
They're originating there or stopping there?
Well, this is where the occlusion is.
Okay.
Is in the cerebral arteries.
So it's still starting from the heart and then traveling.
That's an emboli. A thrombus
okay.
is here,
okay.
right? It's starting to collect.
That plaque and it's
That
closing
plaque.
the lumen.
Right.
Okay.
So a thrombus hasn't moved. It originated in this cerebral artery, and this is where the occlusion is.
So what would cause something like that, like a thrombi in the cerebral arteries?
I'm sure
build up a cholesterol somehow.
Yeah, cholesterol,
So it's quite possible that they have, before this, other thrombi within their system, correct?
potentially, yeah. Also, when we're talking about ischemic strokes, a small percentage, 15%, will have this thing called a transient ischemic stroke, where they have this occlusion here,
Mm-hmm.
but it's transient. So, like, let's say you get this occlusion, right? Blood can't go through here.
Mm-hmm.
You're having an ischemic event. But in transient ischemic attack, you're going to have fibrinolysis happen.
Which is scar tissue, right?
Fibrinolysis, if we think of blood clotting,
The breakdown of the fibrin clot.
we're going to have a breakdown of this clot. And so fibrinolysis will occur. So this will start to get broken down
Uh-huh.
and blood can flow through. And so this transient ischemic attack will only occur for minutes. All right? And then you'll restore blood flow again. 15% of patients with strokes will have this first before actually having the stroke. Everybody good with that? Interesting. Okay. Then there's the hemorrhagic stroke. That's separate from this. But I'm going to use this picture probably again for it. I'll draw the crappy picture here as well. Like this. Okay. You just have this circle of cerebral arteries. It's not perfect by any means. It's just a picture here. So when we're talking about hemorrhagic stroke, this is now where you're going to have blood coming in here, right? And where you see branching, I should draw this better, like a branch here. This area right here is a weak point in the blood vessel. Think of it this way. So whenever you have a branch, blood is flowing like this and then it goes off, right? It's hitting that where it's branching. And so constant hitting of that blood where you have branching, this is under more force than the rest of the areas of the blood vessel. Can people see that?
Kind of like the carina in the respiratory system.
The
Where you branch out and there's that one spot right there.
that's because that goes down
Mm-hmm.
more. It actually is the one is at a more angle, so it's harder to get obstructions in that one side because it's angled more, where the other one's more straight up and down. This is more pushing forces at that area where it's branching.
Mm-hmm.
That's different. Okay? It's sort of like if we were talking about, I'm trying to think of a good example here. Oh, okay. Whenever you put your pants on, right? Where are you putting the most force? Where do you think in your pair of jeans you put on the first place you're gonna have damage occur.
In between the legs.
What?
Oh, yeah, those two.
Where? Maybe there, because there's pressure. I'm thinking here, where you're buttoning it up. You're constantly pulling at that.
Mhm.
Now we're talking about a pulling force rather than a pushing force. But this is the area you always undo it to go to the bathroom. You always button it up. This is always having more force, but a pulling force. And so buttons pop off there, depending upon how good of a quality of jeans you have.
Mhm.
This is just because there's more force constantly being put on this area. So then it's going to start to weaken and balloon out like that.
Mhm.
And as blood is continually coming here, it's going to keep going in here. This is going to get weaker and weaker.
Mhm.
And then it's going to burn, it's going to get damaged, the blood's going to go out. That's a hemorrhage. This is actually an aneurysm, all right? So hemorrhagic strokes are caused by aneurysms, and aneurysms are the weakening of these blood vessel walls where you have branching in this circle area with these cerebral arteries. Everybody go with that? Okay. Now, the other thing, and so that's going to be a big thing with this subarachnoid is cerebral aneurysm. It's going to lead to that. I don't think I'm going to spell this correctly. The other thing that will happen here is that there's this thing that's called atriovenous malformation. Atriovenous malformation is where there is no capillary bed between the arterioles and the venules. And because of that, it creates, again, another area of high pressure because you're not having that blood go from this one blood vessel into like a pool of water.
Mhm.
You know what I'm saying there?
Because you don't have as much surface area.
Right, you have less surface area. It's going from an artery to a venule.
Mhm.
And so that in that area, in that venule, you have a lot of pressure. It's not distributed through a bunch of capillary beds in those true capillaries. And the similar thing will happen where that wall, because it's under high pressure, but it's a venule that's supposed to be a low pressure system, will burst. And you'll get hemorrhaging. Right? That's this atriovenous malformation is a genetic, I believe, a genetic etiology there. Some people just don't have in certain areas a capillary bed between the arteriole and the venule. All right? But it could lead to subarachnoid hemorrhagic stroke. In regards to the intracerebral one, so this is again happening where that subarachnoid space is, okay? And in that pia mater will have blood vessels. And then you'll get these bursts, these hemorrhaging occurring. When we're talking about intracerebral, this one is going to predominantly occur around the basal ganglia and the thalamus. You'll have a hemorrhaging, and I'm making a speculation here, but I would imagine since it's happening in these areas around here, we're really talking about maybe that choroid plexus potentially. So those ventricles that are in the inner part of the brain, you're filtering out stuff from the blood plasma to make cerebral spinal fluid. So we're really talking about something going internally here, right? And so potentially this is from those choroid plexi hemorrhaging around. That's my speculation. But where we actually get to the bleeding is in this inner area. Okay? Is everybody okay with that? Any questions? No? So 2 types of strokes. Then you have this thing called stroke sequelae. So you've had a stroke. You survived the stroke. Yes, hemorrhagic strokes typically less survivors with that one than an ischemic stroke. Stroke sequelae is where you've had the stroke, but now you are in a recovery state. But you will have deficits, all right? And it depends upon where you had that stroke occur, all right? You could have language deficits, and so when that happens, it's called aphasia.
So what
Right.
kind of aphasia would it be? Like, you wouldn't be able to speak, or would you not be able to understand speech?
It depends upon what area is affected. Did the Wernicke or the Broca's area? If we're talking about Broca's, you're not able to speak. If it's the Wernicke, you're not able to interpret, okay? So when we're talking about aphasia, so stroke sequelae, I'm spelling this wrong, sorry. This is recovery after a stroke. And you will have deficits because you had a stroke. You had an area that became an infarct. There's damaged tissue. You had necrosis occur, especially with ischemic, because when we're thinking about stroke sequelae, we're really talking about an ischemic event in the recovery afterwards, because hemorrhagic tend to be more likely those people die. Now, deficits are going to be, you can have language. If it's language, we're talking about aphasia, and it's going to, depending upon the severity of the damage and where, you can have these many manifestations occur. Not being able to talk, not being able to understand what somebody's saying. You could also have cognitive. This is, just think of what like cognitive means. This is like memory loss, not being able to reason anymore. You might have a change in personality here. Think about having damage to that frontal lobe in cognitive. And then the last one is memory, or not memory, that one's memory, motor / sensory. And so in these ones, you could have paralysis of a certain area. And yes, this is like, remember, you have contralateralization here, right? So if you have damage to the left side of a motor region, it's going to be the right side that you have that paralysis, okay? Same with sensory. If you have damage on this left side, you might not be able to recognize that your arm is your arm, for example. That would be a sensory manifestation. So that is actually called hemi-attention. Not recognizing a body part as your own. That's what hemi-attention means, all right? And the motor one is paralysis, if it's that severe. When a person who's the next sequence after a stroke is this recovery state, the thing that they're going to look for recovery is this thing called spasticity. So think of, hey, motor, your paralysis, right? You can't move your arm. You can't contract it. I mean, also with this, you're going to have muscle atrophy. If you're not having that motor end plate, the motor neuron exciting a skeletal muscle, it'll atrophy, right? So that could be another part of this. But let's say paralysis occurs. The spasticity is a good sign, actually, in recovery. What ends up happening is that these people will start to have more muscle tone and have a reflex. It might stay like that, though. But if they're able to do that from being paralyzed, that means they're on their way to recovery and they might actually start to get movement in that area that's paralyzed.
Could they also have contractures though? The shortening of the muscle tissue? Because I know that some residents, they have to do like constant range of motion so their muscles don't short, so they don't stay like this all the time.
Right, so this is a thing, this spasticity is like, okay, you're on your way. They're gonna be going through physical therapy and working with that muscle, but the simple fact that they're able to do that and create cross bridges means that that muscle now is being excited by a motor neuron, where before when you had the paralysis, it wasn't. And so when you see this happening, that means that they're starting to have that connection form again. And through physical therapy, you're gonna try to improve that movement. Any questions on this? Okay, the last thing is infections. And there's two types. I'm gonna go through them really briefly. I'm gonna put it over there. And then I'm gonna go around and I'm not gonna talk that much about these infections. Meningitis and encephalitis. Both of them are going to cause inflammation, all right? This one here is from a pyogenic bacteria, which then, now we're talking about that liquefactive necrosis occurring here. You're going to get a purulent exodus, and you're going to have liquefactive necrosis.
Isn't there also viral meningitis?
Yeah, there is viral meningitis. For this particular thing, we're thinking meningitis is a pyogenic bacteria. When we're going into encephalitis, this is where we're talking about herpes simplex 1. I'm totally making this very broad.
You can have both of them at the same time though too as well, right?
Oh, encephalitis and meningitis?
Yeah.
Oh, I have no idea. I said I'm just doing the quick and dirty here. I
Okay.
didn't really read about it. I'm like, okay, let's move. We're just gonna keep this simple. Okay, this is usually viral. I'm doing the most common things. Let's put it this way. This is normally bacterial. This one is usually viral, okay? Of course, we're gonna have exceptions to this general rule. And the viral part of encephalitis is going to be herpes simplex 1.
Enhanced cold sores?
Right, so you could get this from direct contact. An oozing sore, when you kiss someone and you have a cut on your lip and they have this oozing sore and then you get herpes. So direct contact. Also, you can get this from mosquito bites as well. So mosquito can bite you and give you herpes simplex 1. Herpes simplex 1 can be dormant in nervous tissue. And then an environmental trigger could activate it in that nervous tissue. And then you're going to get inflammation occur. And the thing that is going to increase the chances of this is of it invading brain tissue is going to be hypertension. So, and then hypertension followed by some kind of vascular disease. So you're having hemorrhaging occur, that kind of stuff. And now this blood is not being blocked, and this virus is being able to go into brain tissue and cause inflammation within that brain tissue. And that's it.
Mm-hmm.